Hello, my name is Cynthia Wells, and my topic today is the cardiovascular system. I do not have any disclosures to reveal at this time. I'm going to start by talking about physiology and anatomy of the cardiovascular system. So first, I'd just like to talk about the heart as a mechanical pump. It's actually a pretty amazing pump, and there's two pumps that propel blood through two vascular systems that are arranged in series. First, there's a pulmonary circulation. This is dependent on the right ventricle or the right heart. It has a low resistance, high capacitance vascular tree with bidirectional gas flow, whereas the systemic circulation, which we more traditionally think of as the left heart, functions to deliver oxygen and nutrients to the body while removing carbon dioxide and metabolites. Whenever we talk about the heart, we have to think about each cardiac cycle as a discrete event. And we can first talk about the electrical function. The heart is very unique in that it can function independently as an electrical unit. There's activation of the entire contractile apparatus, which begins at the SA node. The SA node is located at the junction of the superior vena cava and the right atrium. The regulation of the cardiac cycle is coordinated by a series of impulses that are produced by these specialized pacemaker cells. Following activation of the SA node, conduction follows to the AV node and throughout the His-Purkinje fibers. Conduction then, also I want to note, is delayed through the AV node in order to allow for complete ventricular filling. This image gives you a description of how the action potentials vary throughout the electrical system in the heart. You can see at the level of the SA node, it's more of a simple sinusoidal wave. And I'll give more detail about that in a moment. Whereas the conduction progresses through the system, at the ventricular muscle, the action potential looks very different. And you can see that there's a plateau phase, which allows for ventricular systole. And at the bottom of this image, there's actually a waveform that correlates with an EKG waveform. And you can see that activation of the SA node correlates with a P wave, whereas the ventricular action potential correlates with the QRS complex or systole. So a traditional action potential of a ventricular muscle fiber is shown in this graph, and you can see that there are 5 different phases. I won't go through them in detail because I give you details of the electron movement in the following slides. However, I will note that it's very important to know these different phases because this is where we use medications to treat such things as cardiac arrhythmias. For example, phase 2 represents a plateau, and there's a slow influx of calcium through L-type calcium channels. And this is where drugs such as calcium channel blockers will work. Here's the details of each of the phases and what will happen. Interestingly, phase 4 was the resting membrane potential. This is an energy-dependent process, an enzyme that is used to maintain the resting membrane potential, and it's, as I note, energy dependent. The action potential at the level of the SA node, as I noted before, it looks like more of a simple waveform with only 3 phases. And the reason for this is where the primary activation of the electrical apparatus begins. The resting membrane potential is less negative, and there's regular spontaneous depolarizations at this node because there's a slow influx of sodium that is continuous. I just note that here as well. One thing that's unique about the cardiac myocytes also is there's a process called excitation-contraction coupling. When there's depolarization of the sarcolemma or the membrane, there's deep activation also along the T-tubule system. This leads to a small influx of intracellular calcium. However, the cardiac myocytes are very dependent on high calcium concentrations, and that's because with that small amount of calcium that's released, there is a triggering of a large amount of calcium release from the sarcoplasmic reticulum, which leads to calcium binding to troponin C and activation of the contractile apparatus. This is why it's so important for patients, especially patients who have any cardiac dysfunction, to monitor their calcium levels and treat them appropriately. I've noted the details of that system here on that slide. Next, I want to talk about a normal EKG. We're all familiar with the PQRST complex. I want to go over a little bit more detail. The SA node activation begins with the P wave, or impulse generation. The PR interval begins with a P wave and proceeds through the QRS. And this correlates in the cardiac cycle as the impulse traverses the atria to the AV node, as well as the delay in the AV node. The QRS complex then describes depolarization of the ventricular muscle. The impulse spreads down the bundle of His and through the Purkinje fibers as the excitation of the ventricular muscle spreads throughout the entire ventricle. This is known as systole and correlates with the QRS to T complex. The ST segment, again, is the period between completion of depolarization and the beginning of repolarization. And a T wave represents normal repolarization of the ventricular myocardium and the onset of diastole. So how is heart rate controlled? Heart rate is normally determined by the pacemaker activity of the SA node. The intrinsic rate of this node is 100 to 115 beats per minute. However, most patients do not live with that resting heart rate. There's a process called overdrive suppression as well that occurs. Within the heart, the AV node also has an intrinsic rate, which is typically 40 to 60 beats per minute. As well, the ventricular muscle itself can generate its own heart rate of about 20 to 40 beats per minute. But within the heart, whichever site has the highest heart rate will overdrive the others. So why, again, is the resting heart rate not in excess of 100 beats per minute? Well, this diagram shows you that there's innervation from the sympathetic nervous system. So typically, the sympathetic nervous system would take the heart rate higher, but there's also vagal innervation, which typically leads to a resting heart rate in the range of 60 to 80 beats per minute. So depending on the level of stimulation, the heart rate will vary. Faster heart rates require a decrease of vagal tone along with sympathetic activation. The heart rate can also be modified by circulating catecholamines via beta-1 adrenoreceptors. And typically, the maximum heart rate that you would expect any patient to achieve is 220 beats per minute minus their age in years. So the cardiac cycle, we talked a lot about the electrical sequence of events. However, we can also correlate this with the mechanical events that happen during a single heartbeat. The following diagram is typical of what will actually happen within the heart. So we have our EKG at the bottom of the screen. However, there's various pressure waveforms that we can also follow. The top waveform represents the aortic pressure, and you can see with the QRS complex, that's the onset of systole, and this is when the aortic valve opens. As well, the dotted line represents a left ventricular pressure waveform, and there's a rapid rise in left ventricular pressure at the onset of systole. I always note in the aortic waveform, there's this little notch that's called the incisura, or when the aortic valve closes, and this is the diastolic runoff following the incisura within the aortic or arterial tree. The cardiac cycle in more detail, what's happening within the heart, you can start at the top, and then during late diastole, so this is during filling of the ventricles, both sets of chambers are relaxed, and there's first passive ventricular filling. This is followed by atrial systole. Atrial contraction forces an additional amount of blood into the ventricles, allowing for complete filling by the end of diastole. Isovolemic ventricular contraction follows immediately after diastolic filling. And this is the first phase of ventricular contraction. What occurs as the ventricle starts to contract is that the atrioventricular or mitral and tricuspid valves will close, but until enough pressure is generated, the aortic valve or pulmonic valve will not open. This is isovolemic contraction. The next phase, once your semilunar or aortic and pulmonic valves open, is ventricular ejection phase. And this is where we saw the rapid uprise in the pressure waveform as blood is ejected from the ventricles. And the last phase is isovolemic ventricular relaxation. As the ventricles relax, the pressure drops within the cavity, and then blood flows from the atria back into the ventricles. And this represents an entire cardiac cycle. As I had noted, you can follow on an EKG or pressure waveforms. I've given more detail about the cardiac cycle in the following couple of slides. Again, diastole is representative of relaxation and systole is contraction. The stages of diastole were early diastole, when the semilunar valves open, followed by a rapid filling, and the second stage is atrial systole. Systole is representative of the contraction phase, and the following three stages are described as follows. Here's a more descriptive view of the cardiac cycle. I've included the additional information of the phonocardiogram, or the heart sounds that you hear. And this is represented by the actual closure and opening of valves, which you hear when you listen to patients. And you can correlate if you have a systolic ejection murmur, such as aortic stenosis, it would correlate with the arterial waveform or the aortic waveform during systole. The next graph is a description of the actual intracardiac pressures that you would expect in a normal heart. Initially, when you're tracing the blood throughout the heart, the CVP, or pressure in the right atrium, is rather low. We expect to see a pressure less than 10 or a mean of 4. RV pressures, what happens during systole is there's a rise in pressure, but the RV diastolic pressure will equilibrate with the right atrium, and so the RV diastolic pressure is typically equal to CVP. As blood passes into the pulmonary artery, there's a rise primarily in the diastolic pressure, whereas the PA systolic pressure will equal the RV systolic pressure. So you can see here that the mean systolic range in the pulmonary artery, as listed here, actually in the top left of this diagram, is equal to RV systolic. Interestingly, then as blood passes through to the left atrium, the mean drops to a pressure of approximately 8, as I said, in a normal healthy heart. And then as blood passes into the LV, the systolic range will equal whatever the systemic pressure is, because the LV must generate enough pressure to flow into the arterial tree, and the end diastolic pressure again equilibrates with the left atrium. And the last pressure that we will typically correlate with intracardiac are your systemic pressures, and this is equal to the blood pressure that we typically see. When placing a right heart catheter, we can follow pressures throughout the right side of the heart through to the pulmonary artery. Initially, this balloon-tipped catheter starts in the right atrium, and we'll see that this correlates with CVP. You can follow the waveform then as it enters the right ventricle, and you'll see there's a peak systolic pressure, but your diastolic pressure, mean diastolic pressure, correlates with CVP. But the primary indication that you've passed into the pulmonary artery is that you see a change in the morphology of the waveform, but there's also a diastolic step up. And this is because during diastole, there's closure of the pulmonic valve instead of equilibration with the pressure in the right ventricle. And if the catheter is passed into the distal pulmonary artery tree, you'll get a wedge pressure, which correlates with left atrial pressure. And you can see the diastolic wave, or the pulmonary artery waveform as described there. So I'm going to shift gears here and talk a little bit about systolic function, now that we've gone over the cardiac cycle. So systolic function, or ventricular systolic function, is the driving force that each ventricle must use to drive blood throughout the cardiovascular tree. It's dependent on loading conditions, or filling, and contractility. We typically think of systolic function in terms of cardiac output or cardiac index. Cardiac index is just a way of normalizing cardiac output for different sized patients, or it's a cardiac output over body surface area. Heart rate is a function of cardiac output, as I had noted. The heart rate, as I had described earlier, is an intrinsic function of the SA node. And cardiac output in a healthy heart is well maintained between heart rates of 50 and 150. And the way that this is done is that there's a change in stroke volume as heart rate changes. You can see as heart rate goes up, stroke volume will decrease in order to maintain a constant cardiac output, and this is under stable conditions where there's not an increase in demand. You can see cardiac output's well maintained and with increasing heart rate, but stroke volume comes down. So cardiac output is, there's multiple things that contribute to changes in cardiac output. A normal adult at rest has a cardiac output of 4 to 6 liters per minute. Heart rate is affected by the autonomic nervous system, electrolytes, temperature, and intrinsic hormones secreted by the adrenal medulla. Stroke volume represents the amount of blood ejected with each contraction, and as I noted, it's affected by preload, afterload, contractility, as well as circulating neurohormones. So stroke volume, as I noted, is dependent on filling or preload. Preload in its purest form is described as muscle fiber length at the end of diastole, and while afterload is the tension against which the muscle must contract during systole. Contractility is an intrinsic property of the muscle itself, or its ability to shorten during systole. Stroke volume is also influenced by things such as wall motion abnormalities for patients who may have had an ischemic event or infarct, scarring of the wall of the muscle. Also, valvular dysfunction has a great influence on stroke volume, whether they're stenotic or regurgitant lesions limiting the forward movement of blood into the arterial tree. Preload, I'll describe a little bit more. It's also defined as LV end diastolic volume. Estimates of preload, we can look at a pulmonary arterial or pulmonary wedge pressure, or we more typically think of it in terms of central venous pressure. Starling's law describes the relationship between preload and contractility, or sarcomere length. This preload in its, again, purest form is thought of in terms of a constant heart rate, and Starling's law is true until excessive volumes are reached. And this is when stroke volume actually starts to decrease. And this is what we see clinically in the face of a dilated cardiomyopathy, when patients actually start to lose stroke volume. The following graph describes this phenomena, what happens when at rest, a typical patient, if you increase, or a healthy patient, let me say, if you increase preload or end diastolic volume, there's an increase in stroke volume or ventricular performance. However, in those patients who have dilated cardiomyopathy, what will happen as you add ventricular volume, the sarcomeres stretch to the point that they lose contractility and stroke volume will actually fall off. And you can see by the arrow described on that graph. So what are determinants of ventricular filling or preload? Well, most important is venous return, or what is the patient's circulating blood volume. There's also distribution of blood volume, and this particularly comes into play for patients under anesthesia. We have their positioning, intrathoracic pressure, as well as venous tone, which anesthesia has a tendency to decrease venous tone. Rhythm is also an important factor in ventricular filling. The most typical rhythms where we lose atrial contraction or AFib or flutter, as well as heart rate. Heart rate, as heart rate increases, your diastolic time decreases more than systolic time, which limits ventricular filling time as well, and also limits preload. Afterload is equal to ventricular wall tension during systole. This is approximated by a patient's systolic blood pressure, or if a patient has aortic stenosis, this is representative of afterload. Or we can think in terms of systemic vascular resistance. However, the calculation for systemic vascular resistance requires invasive monitors in order to obtain a CVP and more accurate cardiac output. The relationship between stroke volume and afterload is described in the following graph. As afterload increases, stroke volume will typically be maintained for a certain amount of time as contractility can increase to overcome an afterload that's elevated. However, at a certain point, if the systemic blood pressure becomes so elevated, the heart will not be able to eject. And you can see for patients who have some element of myocardial dysfunction, there's a more linear relationship between the increase in afterload and a decrease in stroke volume, to the point that a patient with severe myocardial dysfunction is not able to overcome elevations in blood pressure and tolerate that very well. They will instead lose stroke volume, and this will be shown as a decrease in systemic blood pressure. So I mentioned that afterload is the tension against which the heart must contract. Well, the wall tension that's generated within the ventricle can be described by the law of Laplace. But the interesting thing also is that wall tension is a very high oxygen demand state. As wall tension increases, the ventricle must consume more oxygen to contract. And by the law of Laplace, wall tension is proportional to the pressure within the ventricle as well as the radius. As radius increases, wall tension increases as well. Interestingly, in the denominator of this equation is wall thickness. As the wall tension increases within the either ventricular cavity, a typical adaptive mechanism is that the ventricle will start to thicken. Thickening of the ventricular wall is actually a compensatory mechanism to preserve the ventricle itself and decrease wall tension, and therefore decrease oxygen demand. Right ventricular afterload. I haven't talked about the right ventricle very much, but I just wanted to make note that you must always assume that it's equally as important as the left ventricle, because if the right ventricle is not functioning well, you will not get filling of the left heart. The right ventricle is dependent primarily on pulmonary vascular resistance, and this equation as well can be calculated more exactly. But typically we will rely on a PA catheter to give us pulmonary arterial pressures and then as a monitor of right ventricular performance and afterload. So contractility is the third determinant of stroke volume when thinking of also cardiac output. Another word for contractility is inotropism. This is the intrinsic ability of the myocardium to pump, or muscle performance. It's measured, again, in its purest form in the absence of changes in preload or afterload. It's dependent on intracellular calcium concentrations, oxygen supply, as well as functional myocardium. And it's easily altered by neural, humoral, or pharmacologic influences. Myocardial contractility is depressed by a lack of oxygen, acidosis, a depletion of calcium or catecholamine stores, a loss of functioning muscle, such as after a myocardial event, as well as most anesthetic and antiarrhythmic events or medications. So how do we assess ventricular systolic function? Well, in a lab we can look at ventricular pressure volume loops. However, this is not always practical in a clinical setting. A pressure volume loop looks at the amount of work that is done during the entire cardiac cycle. And also on this graph, the red dotted line represents, the slope of that line represents contractility, while the black dotted line represents ventricular compliance. However, in a clinical setting, we typically talk about ejection fraction. Ejection fraction, it can be easily measured subjectively by echocardiography when you calculate the end diastolic volume minus the end systolic volume all over your starting volume times 100. And this is a number that is easily correlated across specialties, with normal being 60% or greater. Diastolic function of the ventricle is also defined as lusitropy. This depends primarily on preload and ventricular compliance, or the ability of the ventricle to stretch and accept volume during diastole. Relaxation is an energy-dependent process. What happens during diastole is the calcium that was released into the cells has to be taken back up into the sarcoplasmic reticulum, and this requires ATP. Diastolic function can be again affected by preload, passive chamber stiffness, elastic recoil of the ventricle, as well as interaction between the two ventricles, and atrial or pericardial properties. Loss of atrial contraction will limit diastolic filling, as well as if there's any loss of stretch in the pericardium, the ventricle cannot fill as well during diastole. As well, catecholamines can affect diastolic function. Diastole has 4 phases. We had noted earlier there's isovolemic relaxation. This is the early phase before the mitral valve has opened. Immediately after mitral valve opening, there's the E wave as seen on a pressure waveform. This represents early filling. Diastasis is when there is equilibration between the left ventricle and the atrium. And then atrial systole is represented by the A wave. The following graph shows ventricular compliance curves. We talked about a normal heart will accept volume with a gradual rise in LV pressure. However, a stiff heart, such as a severely hypertrophied heart, will only accept a small amount of volume with a rapid rise in pressure. And you can see this is represented by the steep curve on the upper waveform. And then the lower represents a patient who has a dilated heart. It takes a large amount of volume in order to fill the ventricle, and you only see a rapid rise in pressure when that heart is maximally filled or typically more dilated. What are factors that affect ventricular compliance? Well, as I had noted, there are intrinsic factors such as scarring from ischemia or infarct, but the most common cause of ventricular dysfunction or lack of compliance is left ventricular hypertrophy. Other things are extrinsic factors such as the pericardium or increased airway or pleural pressures as well can exert external pressure on the heart. And because the RV typically is thinner walled, it is more compliant, but it's also affected earlier when there's external compression on the heart. Diastolic dysfunction is a change in ventricular diastolic properties or a decreased ability of the heart to fill. Interestingly, diastolic dysfunction is now typically reported on patients' echocardiograms, as well as recognized in the pathophysiology of congestive heart failure, with approximately 50% of all heart failure patients being given a diagnosis of diastolic dysfunction. What happens in the face of diastolic heart failure is there's an elevation in the left ventricular end diastolic pressure, or filling pressure. This leads to an elevation in left atrial pressures, and that pressure is transduced back into the pulmonary circulation, leading to pulmonary congestion and pulmonary hypertension. And if this process continues, it will lead to an elevation in your right ventricular filling pressures as well, and also an elevation in CVP. Eventually, this can lead to ascites and peripheral edema for patients. So when monitoring a patient's cardiac output, it's important to be able to tell, is it a function of the heart itself, or is the heart meeting the demands of the body? The Fick equation is used to describe this concept. Oxygen content of the venous blood is measured in the pulmonary artery, and this represents, sampling of the pulmonary artery represents a true mixed venous oxygen saturation because you've also collected blood from the coronary sinus, which is the blood draining back from the heart. The Fick equation is indicative of global metabolic requirements of the entire body, and there's a relationship between O2 delivery and O2 consumption, which is VO2. This is a linear relationship until a critical point is met, and that's when consumption may exceed supply and cells will revert to anaerobic metabolism. A low mixed venous oxygen saturation reflects inadequate O2 delivery or increased consumption. A normal mixed venous oxygen is 75%, or give or take. The Fick principle is described by the following equation. You have saturation of the venous blood is equal to arterial saturation minus oxygen consumption all over 1.34, which is a constant, times the hemoglobin concentration times cardiac output. So if there's a drop in a mixed venous oxygen level, it must be due to one of four things. Either there's a drop in the arterial saturation, there's an increase in total body oxygen consumption, there's a drop in hemoglobin, or a drop in cardiac output. And for patients who are anesthetized, it's typically straightforward to monitor most of these variables. For example, you can monitor hemoglobin concentration and arterial saturations very easily. Through the use of a PA catheter or TEE, you can monitor cardiac output. It's the variable that's oxygen consumption that you can assume is elevated if all of the other variables are normal. So now I'm going to shift gears and talk a little bit about systemic circulation. You can see from the first graph that pressure is primarily determined within the arterial tree, whereas the blue bars represents the percentage of blood volume and its distribution within the body. The veins are primarily responsible for the capacitance of a large proportion of our total blood volume. The following chart describes these vessels in more detail. And you can see that the capillaries are responsible for the gas exchange and nutrient exchange. When we talk about venous return or the venous system, as I had mentioned, they're large capacitance vessels. So how do those vessels get blood back to the heart? Well, first, just the act of breathing changes intrathoracic pressure and augments venous return. Our blood volume, or the total volume within the venous system, is affected by urine volume and tissue fluid volume as well. This is a process that changes over time. And there is some element of tonic venous pressure. There can be venoconstriction from the sympathetic stimulation, as well our skeletal muscle contraction helps augment venous pressure and venous return. And that's seen in this picture as well. You can see that contraction of any of the skeletal muscles within the body helps propel blood back through the venous system, and there's one-way valves that help prevent reflux of blood into the venous tree. The respiratory pump, as I had mentioned, helps propel blood through the thoracic cavity and back to the heart, as well as the muscular pump. So blood pressure is the force of blood that's exerted against the vessel walls, and it's primarily dependent on blood volume, as well as compliance within the vascular tree. Systolic blood pressure, as you know, is the peak pressure exerted during systole, and diastolic blood pressure is the minimum pressure as blood is running off. We often just have a systolic and diastolic blood pressure, but quite often we think of patients in terms of their mean arterial pressure when we're talking about perfusion of the various organs. A mean arterial pressure is approximately equal to your diastolic blood pressure plus 1/3 of the pulse pressure. Mean arterial pressure is also highly dependent on systemic vascular resistance. And you can calculate mean arterial pressure also if you have a cardiac output and CVP. So mean arterial pressure is equal to cardiac output times SVR plus CVP, or if CVP is very low, you can eliminate that from the equation. Systemic vascular resistance is most affected by changes in vessel lumen diameter, and this is best described by Poiseuille's equation. Poiseuille's equation describes that the resistance in any system of tubing is proportional to viscosity times vessel length, all over radius to the 4th power. And this is interesting because for patients who have any element of narrowing in their vascular tree, you can see what will happen is the flow within that system will decrease exponentially. Or in the reverse, this graph shows how flow is proportional to radius to the 4th, and as that radius increases, there's an exponential increase in flow. As I noted, the reverse is true. And the vascular system that we most often think of are the coronary arteries. For patients who have any element of coronary artery disease, as those vessels narrow, the flow decreases. So we talked a lot about many of the factors here on this flow diagram. When we described mean arterial pressure, we covered cardiac output, SVR, stroke volume, heart rate, preload, and inotropy. Now I'm going to talk about some of the more peripheral factors here that also affect blood pressure and blood pressure management for patients. These first 4 attributes, as I had mentioned, we talked about. Now I'm going to talk a little bit more about total blood volume, and this is determined by renal handling of sodium in water, as well as some of the neurohumoral mechanisms in more detail. This image describes what can affect vascular tone at the level of the arterial. The arterial tree is primarily responsible for systemic vascular resistance or blood pressure. As well, the arterioles are responsible for distribution of blood throughout the different capillary beds. In the middle of this diagram is a vascular smooth muscle cell, and you can see there are multiple influences. In the blood, there's circulating hormones such as epinephrine, norepinephrine, antidiuretic hormones, serotonin. These are just some of the examples of things that can affect blood pressure or smooth muscles from the circulation. Also within the vascular smooth muscle, there's generation of nitric oxide, endothelin, and prostaglandins, which can contract or relax smooth muscle as well. What's happening at the level of the cells or capillaries can influence vascular tone, such as if there's ischemia occurring, there's the production of lactic acid and electrolytes, which can cause vasodilatation. I describe all of these intrinsic factors, or I list them in a little bit more detail here, just so you can see that there's a lot of things that we don't necessarily think of immediately when we're managing patients' blood pressure. And here's the neurohumoral mechanisms. This is typically your autonomic innervations, such as sympathetics and parasympathetics, as well as circulating catecholamines. So short-term regulation of blood pressure. Other receptors that we have throughout the body include the baroreceptor reflexes, chemoreceptor reflexes, as well as our brain's ischemic response. Arterial baroreceptors help regulate blood pressure very tightly. For a patient, a normal blood pressure is a mean of between 85 and 100. However, this is not always the resting blood pressure. And you can see from this chart that the carotid baroreceptors are located at the carotid bifurcation, and the aortic arch receptors are within the aorta. How these receptors respond is if there's stretching of the arterial wall, there's a change in the firing of the impulses that are sent back to the brain. The carotid sinus is much more sensitive to blood pressure changes in the range of 60 to 100 millimeters of mercury, whereas the aortic arch receptors are less sensitive. It takes a much greater swing in blood pressure in order to induce firing of these receptors. The following diagram shows this in a little bit more detail. If blood pressure decreases, there's a decrease in baroreceptor firing, and the cardiovascular center of the brain, which is in the medulla, will increase sympathetic tone and decrease sympathetic or parasympathetic outflow. This leads to vasoconstriction, or an increase in SVR, tachycardia, an increase in inotropy, as well as, this should say an increase in cardiac output. This is an immediate response that these receptors respond to a decrease in blood pressure. Chemoreceptor reflexes are also located within the body. And this is seen as there's receptors within the brain that are responsible for changes in oxygen content of the blood, carbon dioxide, and pH levels. The central nervous system responds from high carbon dioxide or hypercarbia, as well as low pH levels, in order to increase systemic vascular resistance. These signals are traversed back to the brain via the glossopharyngeal nerve, the vagus nerve, okay? And the signals are then sent back out primarily via the sympathetic chain. Long-term regulation of blood pressure occurs via the renin-angiotensin system, antidiuretic hormone, atrial natriuretic peptide, fluid shifts within the body, as well as varying levels of epinephrine and norepinephrine. The renin-angiotensin system detects decreases in blood pressure in the kidney. The juxtaglomerular cells in the kidney will detect that drop in blood pressure and secrete renin. Then renin converts angiotensinogen to angiotensin 1. The ACE, or angiotensin converting enzyme, which is actually located within the lung, converts 1 into 2, which will lead to a direct increase in blood pressure by stimulating vasoconstriction, as well as lead to aldosterone secretion from the adrenal cortex. Aldosterone works then back in the kidney to increase water reabsorption and decrease urine volume. And this will then lead to an increase in blood pressure. You can see that this is not an immediate response, but this is a means of longer-term management of blood pressure or blood volume within the body. Antidiuretic hormone, or vasopressin, is another mechanism within the body that responds to changes in plasma osmolality. The hypothalamus detects changes, which sends a signal to the posterior pituitary gland, which is responsible for secreting antidiuretic hormone. The antidiuretic hormone then also affects blood pressure directly by causing vasoconstriction, but it also stimulates water reabsorption within the kidney. These both lead to increases in blood volume and blood pressure. The other mechanism by which the hypothalamus affects blood volume is it stimulates thirst. So blood pressure regulation is also seen at the level of the heart. When there's an increase in atrial stretch, there's an increase in production of a hormone called atrionatriuretic peptide. This is an antagonistic to aldosterone and angiotensin 1 and actually works to lower blood pressure. It works as a direct vasodilator, as well as promoting sodium and water excretion by the kidneys. And as I noted, this is due to increased stretch perceived in the atria, and this would be perceived by the heart as an increase in blood pressure, and it acts to lower it then. As well as epinephrine and norepinephrine. We think of these as hormones excreted by the adrenal medulla that affect blood pressure immediately. But for patients who have chronic changes in blood pressure, there's an upregulation in receptors, and therefore these hormones also act as long-term regulation of blood pressure. The following diagram is complex, but it describes ANP, or atrionatriuretic peptide, in a little bit more detail. With stretch of the atria, it affects the hypothalamus and posterior pituitary, the adrenal cortex, as well as the kidney, to lead to vasodilatation, a loss of sodium and water, as well as inhibiting aldosterone secretion by the kidney, all with a net result of decreasing blood pressure. So I want to shift now and look at the microcirculation. We've talked about blood pressure regulation, which occurs primarily in the arterial tree. But when blood reaches the capillaries, there's three major types. There's continuous capillaries, which are the most common type of capillaries in the body. They have a continuous lining with small holes or fenestration between the endothelial cells, and this allows passage of a small amount of liquids and solutes. These are abundant in the skin and muscle, as well as the lungs and the central nervous system. The second type of capillary, the fenestrated capillaries, have larger holes within each of the endothelial cells, as well as a continuous basement membrane. But these larger holes allow these capillaries to be more permeable to fluids and small solutes. And we see this type of capillary in organs such as the intestines, kidneys, and endocrine glands, where we expect to see larger fluid shifts. And the third type of capillary are sinusoidal capillaries. These have the largest clefts, which will actually allow large protein molecules and blood cells to pass through the vessel walls. This type of capillary is found in the liver, the bone marrow, and the lymphoid tissue. And control throughout the various capillary beds is regulated by smooth muscles that act as precapillary sphincters, primarily in the arterial tree. Capillary diffusion. When we talk about this, we have to talk about Starling's law. It's affected by not only the capillary permeability, but also hydrostatic pressure and osmosis. Hydrostatic pressure is the pressure exerted against the inner capillary wall, and it promotes formation of tissue fluid or fluid extravasating from the capillary walls. Hydrostatic pressure drops across the capillary bed, where it's when there is a loss of volume, there's a loss of pressure. Whereas osmotic pressure is exerted by plasma proteins that are circulating within the blood. The osmotic pressure promotes fluid reabsorption back into the circulatory system. It tends to be constant across a capillary bed due to the constancy of non-penetrating solutes. You can see in this diagram, dependent on the extent of hydrostatic pressure, allowing fluid extravasation from the capillaries, as well as osmotic pressure within the vessel, there's either a net gain or loss of fluid. So Starling's equation describes the net filtration process. And the first parts have to do with the hydrostatic pressure within the capillary as well as the interstitial fluid. And this is minus the osmotic pressure, which is exerted by the tissue proteins. This is true in the capillary beds throughout the body, but also we think of this in terms of the pulmonary circulation with the development of pulmonary edema. For patients who have high left heart pressures, we often see an increase in the hydrostatic pressures, causing an extravasation of fluid out into the tissue. So how is blood flow regulated? It's regulated via the arterial tree, smooth muscle contraction and dilation, but the primary response is due to increases in rate of metabolism. This is triggered by tissue hypoxia, hypercarbia, lactic acid, or increases in other hormones or electrolytes at the cellular level. And as I noted earlier, the endothelial response is another strong and local response. Nitric oxide production can lead to intense vasodilatation, as well as other hormones such as endothelin and histamine. So when talking about specific capillary beds, we're talking about systemic circulation or capillary flow. More specifically, coronary anatomy is important to be familiar with, especially for patients undergoing anesthesia, because the flow into the coronary vessels is dependent on multiple factors. You can see that in the following diagram I'm describing, or describes flow into both the left and right coronary artery, and the lower parts of this graph show that they're not exactly the same. The top graph represents an aortic pressure waveform. The left ventricle receives most of its coronary blood flow during diastole. And this flow waveform actually shows that at the onset of systole, or ventricular contraction, there's actually a decrease in left coronary blood flow to 0, or occasionally there's even reflux of blood out of the coronary artery. Then during diastole, there's runoff or flow throughout the left coronary circulation. Whereas the right ventricle is perfused throughout the coronary or the cardiac cycle. This is because in a healthy right ventricle, the intracavitary pressures never exceed the systolic pressure. And the equation for coronary perfusion pressure is thus aortic diastolic blood pressure minus your left ventricular end diastolic pressure, or this is the pressure during diastole that's exerted out on the ventricular wall. This is critical to keep in mind for patients, especially who have any element of coronary artery disease, because maintaining coronary perfusion is important and diastolic blood pressure is the determinant. How is coronary blood flow regulated? Well, it primarily parallels myocardial metabolic demand. The average coronary blood flow is about 250 mLs per minute at rest, and it's tightly regulated between perfusion pressures of 50 and 120 millimeters mercury. However, blood flow changes with variations in coronary arterial tone in response to metabolic demand. So when thinking in terms of the heart and its oxygen demand, you can think of it as there's a basal requirement of about 20% of the oxygen that flows into the coronary circulation. Electrical activity takes about 1%. Volume work, or the amount of filling in the heart, is 15%, whereas pressure work represents the majority of oxygen demand that the heart requires. This is approximately 64% by some studies. And so when thinking in terms of patients who have high systemic blood pressures or chronic hypertension, this represents a lot of the work that the heart has to do with each cardiac cycle. At rest, the myocardium is already extracting approximately 65% of the oxygen from arterial blood. This is in contrast to most of your tissue that extracts only about 25%. Therefore, the coronary sinus oxygen saturation is normally approximately 30% as blood returns to the right atrium. Therefore, the myocardium cannot meet increased O2 demand with a greater O2 extraction. The only way there can be an increase in oxygen delivery to the myocardium is there must be an increase in coronary blood flow or vasodilatation. And you can see that if this cannot occur, especially in the face of coronary artery disease, myocardial ischemia will ensue. So what affects myocardial oxygen supply? Well, one of the first things we think about is heart rate. As I had mentioned, the LV is perfused primarily during diastole. So by having a lower heart rate, there's more diastolic time and allows for more coronary perfusion. Coronary perfusion pressure is equal to the aortic diastolic pressure minus the end diastolic pressure within the ventricle, as well as arterial oxygen content. So monitoring the oxygen delivery to the blood as well as hemoglobin concentrations are important when considering myocardial oxygen supply as well as coronary vessel diameter. Typically, the vessel diameter may be increased by vasodilators such as nitrates as well as coronary interventions. The relationship between diastolic time and heart rate is described in this graph. What will occur as heart rate increases, as I had noted, there's a significant decrease in diastolic time. So this correlates with coronary perfusion to the left ventricle especially. You lose that time. Typically, systolic time as a portion of the cardiac cycle is not compromised until heart rates are in excess of 100. So factors affecting myocardial oxygen demand. We had talked about basal requirements as the heart is contracting. Heart rate as well. Increases in heart rate increase oxygen demand, as well as wall tension. Elevated preload or ventricular radius increases wall tension and increases oxygen demand, as well as high afterloads and contractility. I noted before that heart rate then is a factor in both oxygen supply and demand. Other vascular beds that are tightly regulated within the body include the cerebral blood flow. Cerebral blood flow is normally approximately 15% of the cardiac output. Excess blood flow is represented by hyperemia or an increase in intracranial pressure. And we know too little blood flow is represented by ischemia. Cerebral blood flow equals cerebral perfusion pressure minus vascular resistance. And what affects vascular resistance within the brain? The primary determinant is metabolic demand. There's pressure autoregulation, chemical control, such as elevations in carbon dioxide or a lack of oxygen, as well as neural control. The following diagram shows what happens to different vascular beds when there's an increase in cardiac output. The lower portion of the diagram shows at rest, cardiac output is typically about approximately 5 liters per minute. You can see a large proportion of this cardiac output goes to the splenic circulation and portal circulation, as well as the kidneys receive about 20% of cardiac output and the musculature about 20%. However, with exercise, cardiac output can go up significantly to as much as 25 liters per minute. And most of this blood is then going to the musculature of the skin, and it's tightly regulated such that flow to such vascular beds as the splenic circulation drop significantly, as well as flow to the kidneys and brain drop off significantly as well. This is through all of the mechanisms that were previously described that tightly regulate the smooth muscle and the various parts of the arterial tree, and this is based on metabolic demand. Regional blood flow during exercise, as I had just mentioned, changes, as well as there's increases in cardiac output and diversion of blood flow to these various trees. So the last part of this talk is cardiovascular pharmacology. The following slides are included for your review according to the ABA recommendations that there's a review of various cardiovascular medications. There's a beta agonists, phosphodiesterase inhibitors, and non-catecholamine agents such as digoxin. I will leave these slides for your review in more detail. I've gone over various medications and their effects, side effects, as well as uses. Epinephrine being one of the most common inotropes that we think of and to treat things such as blood pressure, cardiogenic shock, and cardiac arrest. Okay, that's where I am on time.
5 minutes.
Okay. So, and various other inotropic agents such as dopamine, which is a dose-dependent inotrope. There's low-dose dopamine, which affects receptors throughout the body, as well as with increasing doses of dopamine, you affect beta receptors as well as alpha receptors. At the highest doses, with alpha receptor activation, there's an increase in SVR as well as PVR. But these are high doses that are typically in excess of 10 mics per kilo per minute. The adverse effects, though, of dopamine can predispose patients to arrhythmias, and you'll see a decreased effect in the catecholamine depleted states, as well as interference with the ventilatory response to hypoxia, and it inhibits insulin release. Uses of dopamine include cardiogenic shock, bradycardia, and hypotension in vascular patients. An additional inotrope is dobutamine, which is often used in low cardiac output states. It affects beta-1 receptors, even over beta-2. You'll see an increase in heart rate and inotropy, as well as cardiac output. But potential adverse effects is that there's some vasodilatation with dopamine, which leads to hypotension and tachycardia. Isoproterenol is an active beta-1 and beta-2 agonist. It affects the heart by increasing heart rate and inotropy, as well as decreasing at the same time SVR and PVR. We can also use this drug in the instance of bronchoconstriction to elicit dilatation. Adverse effects of isoproterenol are primarily an increase in heart rate, leading to tachycardia and arrhythmias. Ischemia can also occur if there's a decrease in coronary blood flow due to the increase in heart rate. Uses of isoproterenol include bradyarrhythmias, beta blocker overdose, as well as pulmonary hypertension, because you get some vasodilatation in that vascular bed. And we will see this in the use after heart transplantation to act as a pacemaking agent. Phosphodiesterase inhibitors. There are multiple of these drugs, with the most common being milrinone. The mechanism of action is that it acts as an indirect beta agonist, as well as increasing cyclic AMP within the cells. This leads to an increase in intracellular calcium. The effects are that there's an increase in inotropy, dromotropy, as well as lusitropy within the heart, but also it acts as a vasodilator in the vasculature. The advantages of the phosphodiesterase inhibitors is that it does not induce tachycardia. It's useful for patients who have beta blockade or chronic congestive heart failure, and it will act synergistically with other inotropic agents. And it's especially useful in patients with pulmonary hypertension to lower pulmonary vascular resistance. The adverse effects of phosphodiesterase inhibitors, though, are that they can cause significant hypotension and induce arrhythmias. I had mentioned the treatment of pulmonary hypertension, and this is especially important in patients with right ventricular dysfunction, for it decreases the right ventricular afterload and increases inotropic contractility. Digitalis is one of the oldest cardiovascular drugs that we have. The mechanism of action is that it inhibits the sodium-potassium ATPase, which thus increases intracellular sodium with concentrations within the myocytes and increases calcium also through the sodium-calcium channel. Uses are common with atrial fibrillation or patients with congestive heart failure. However, the concerns with digitalis is that there's a low therapeutic index, and it can lead to digitalis poisoning, and patients will often describe visual disturbances, nausea, and vomiting as a result. Vasodilators that we typically see include direct vasodilators such as hydralazine, nitroprusside, and nitroglycerin. Nasiratide and calcium channel blockers. Hydralazine acts as a direct vasodilator. It's a potent coronary, splanchnic, and renal vasodilator. As well, it affects to decrease primarily SVR and PVR while increasing heart rate and inotropy. It is a reflexive mechanism. The adverse effects, though, is long-term. You can develop a lupus-type syndrome as well as other side effects. The uses are primarily for hypertension or patients who have congestive heart failure. Nitroprusside can be administered as an infusion. A mechanism of action is described here, which all leads to a decrease in intracellular calcium levels within the vasculature. It's used to treat systemic hypertension as well as pulmonary hypertension for patients. As well, it is known to be a very potent arterial vasodilator. So it's very effective, and as well it's titratable. The adverse effects, however, though, are the potential for profound hypotension. It can stimulate aldosterone release. As well, there's concern for toxicity if nitroprusside is run at a high infusion rate over a longer period of time. Nitroglycerin is one of the most potent venodilators. It's very effective at dilating the coronary circulation. As well, it can be given as an infusion or an oral medication or by other means, and it is very effective, the most effective at dilating the coronary vessels for patients who are at risk of coronary artery disease and myocardial ischemia. Uses are also pertinent in patients with pulmonary hypertension or in the ICU or intraoperative setting with hypertension. Adverse effects are that patients can develop a tolerance requiring higher doses, methemoglobinemia, as well as over long term there can be platelet inhibition or activation of the sympathetic system. And nasiratide is the mechanism of action this is a recombinant BNP hormone. It leads to a decrease in SVR as well as venodilatation. The effects are that there's a decrease in wedge pressure or left-sided heart pressures, as well as lowering the systemic blood pressure. Nasiratide does not have direct cardiac effects. Its use is primarily in patients with acute congestive heart failure. Adverse effects, though, like most of the vasodilators, are that hypotension can be profound, as well as bradycardia or other arrhythmias. And calcium channel blockers. Calcium channel blockers are, as I had mentioned, effective in slowing the heart rate as well as decreasing inotropy and inducing some element of vasodilatation. Their uses are for chronic hypertension, as well as pulmonary hypertension, cerebral artery vasospasm, as well as ventricular or supraventricular tachycardias. The various calcium channel blockers I've listed on this slide, and you could see the details of each. Each has are potent vasodilators as well. However, they can be used for different uses. And ACE inhibitors are angiotensin converting enzymes. The effects during anesthesia, though, can be profound. They can potentiate the negative inotropic effects of the volatile anesthetics and augment the depolarizing and non-depolarizing agents. Therefore, it's often recommended that patients withhold their ACE inhibitors prior to anesthesia if this is possible. Adverse effects of ACE inhibitors are renal failure, a chronic cough, and intraoperative hypotension. And then the last drug class is angiotensin receptor blockers. These are a newer class of drugs aimed at inhibiting angiotensin II. I've listed some of the brand names. This leads to a decrease in systemic vascular resistance as well, though there are multiple adverse effects, including hyperkalemia. The use is primarily for patients who cannot tolerate ACE inhibitors. So, and as far as our vasoconstrictors, the primary one I wanted to list is vasopressin. This is a non-adrenergic vasoconstrictor. There's different classes of vasopressin receptors. The V1 receptors, are primarily in the vascular spoon muscle. The V2 receptors are those receptors in the renal collecting system. Clinical applications of vasopressin include refractory hypotension, as well as part of the ACLS protocol in patients with pulseless rhythms. Whereas desmopressin is an alternative form that's used to treat patients with von Willebrand disease and platelet dysfunction. That's all I have for right now. Thank you.